Facing the future. And today we're excited to be joined by Chair Representative Au Belatti, who is the Chair of Health for the State House. And today's subject is one that is very compelling to all of us. It is how do we use technology to transform and perhaps tame the ever-expanding healthcare universe. As our population gets older every day, healthcare costs continue to increase and insurance rates increase, putting a burden on all of our working families. A recent study showed that over $16 billion a year could be saved through the use of technology and telemedicine in the health. Today we're going to look at this complex subject and see, will this be the tool to allow us to tame the healthcare universe, or is this a silver bullet that is in need of much more ramifications? Chair Belatti, thank you for joining us today.
Thank you for having me here. It's always good to be able to chat with you.
Excellent. Telehealth, telemedicine, the buzz, you hear all about it all the time, but in your role as Chair of Health, what does it mean to you, and what are some of the ideas you think that it offers as so far as the challenges in the healthcare system?
Telehealth is going to allow us to do better care coordination throughout the community. And in our island state, that's very important. It's very important to the islands of Maui, Kauai, Big Island. What telehealth is going to allow us to do, and we did pass a bill this session, Senate Bill 2469, that was authored by Senator Roz Baker in the Senate side. On the House, it was introduced by Representative Justin Woodson. So this is something that all of the neighbor islanders have really collaborated on. And what that bill does is going to allow for the charging of services for telehealth by insurance companies. It's going to require equivalent healthcare insurance coverage for those services. And then it's also going to include and say that what's going to be covered can be provided by a range of qualified health providers. These will include primary care providers, mental health providers, physicians, and very importantly, APRNs on the neighbor islands. So what telehealth is doing, and I think what technology is doing, is allowing us to connect more people together to share information in a safe way to be able to provide better access to care.
Excellent. One of the ways that it's been discussed as far as telehealth can be used, especially for our neighbor island population, is remote analysis. Areas that have low volume, perhaps smaller clinics, can use this remote analysis to get access to specialists and others. Do you think that that is going to be as powerful as it has been laid out to be? And do you see any ramifications or drawbacks vis-a-vis perhaps the lack of demand now to get specialists physically into the rural areas?
I think it's going to be part of allowing for greater access. Will it be the fix-all to our workforce shortage needs? No, it won't. We still have to encourage things like the residency programs that bring providers out to the neighbor islands and to the rural areas. We cannot just rely on the technology, the telehealth services, that remote access as the way to go, but it's going to be a critical and important piece. I think one of the other things that the legislature has done, in addition to passing this telehealth bill, is we are looking at ways to support collaborations. So on Hilo, we funded the Hilo Medical Center Primary Care Residency Program. So it's using both the technology and then connecting and creating teams of people that are going out into the community. It will be always a challenge to get specialists out to the neighbor islands, but by coordinated care, by these kinds of collaborations that are encouraged and facilitated by technology, we begin to solve the issue of access and workforce shortage.
And you bring up a good point in the Hilo Medical Center, because that touches on the area of pooled resources in telehealth and telemedicine, whereby teams have access to the same data and analysis.
Yes, so that's another important thing that we've been doing, and I think you're really aware of this, but the Hawaii Health Information Exchange, not to be confused with the Hawaii Health Connector, but the Information Exchange is something that we've utilized federal funds for, and this year we formally recognized and designated that Hawaii Health Information Exchange as the fully operational statewide health information exchange. And that what that's doing is setting kind of a standard for the sharing of medical records and data, and saying what is going to be that standard, and then allowing organizations in the community to share and access that information.
Has there been proprietary concerns or concerns of different providers perhaps saying that they don't want to release the information for confidentiality reasons? How does that thwart the effort of information exchange?
I think that has been a sticky wicket that they've been dealing with from the very beginning of electronic records being in existence. I think, though, that everything is moving towards greater transparency, to coordination of care, to being able to see the data and what's happening on a population-wide basis. So I think they're navigating through that. The healthcare providers and the hospitals are navigating through that kind of sticky wicket right now.
Well, and it actually brings up a very good point, and it's poignant, and it also goes to the remote pooling, issues as to security, cybersecurity. As you've been engaged in this discussion with the various stakeholders to develop this health exchange ecosystem, how prevalent has been IT concerns and security, and what do you think needs to be done or is being done to address cybersecurity within this realm?
I think it's always been top of the mind for everyone involved in medical records, because there are very strict rules around privacy and medical information, HIPAA. There's also very big consequences if that information gets released. I'm not a techie, so I have to trust that when they are talking about it, that it is a high priority and that that's what they're focusing on. No one wants to be exposed to that liability. So I think they're navigating through that, and we always have to be vigilant.
Yeah, and but that does bring up the counterbalance of HIPAA. For instance, in one of my conversations with somebody, a professional on the neighbor island, they were lamenting that HIPAA was actually slowing or thwarting the evolution of exchange of information because of all their rigorous controls for privacy. Do you see, I guess, in the balance of privacy versus being able to carry this out, do you see HIPAA perhaps being evolved or trying to evolve it in such a way as to create less rigorous?
I think it will have to evolve, but that's at the federal level. We do have our own kind of state privacy protections as well. And I think one of the things that we've seen happening in the healthcare arena is that, especially with mental health records, and we know that there are a lot of individuals who interact with both the mental health system and the penal system. So some of the bills that we've worked on this year was also to ensure greater coordination and sharing of those records, particularly when you have individuals who may be, again, in the penal system, and we have to get their information right away to know whether or not they should be put in the state hospital versus the prison system. So when you ask, will it evolve? Yes, and we're part of that evolution, so we're allowing greater, we're instructing the courts to share information. But again, there's that balance, like you said, we always want to also protect privacy. So when we alter the laws or change it in a way that allows sharing, we're also very conscious that we also have to limit that sharing.
But the sharing, in particular in the case of public safety in the mental hospitals, this offers a great opportunity for the public, a double win, if you will, to not only have the type of information exchange, but to also be able to allocate fixed resources and to ensure that people who need to go into mental health services get there and are not in the prison system and vice versa, right?
Precisely, and the more we know about where people should be, especially for mental health, we also can understand where we need the community resources. During the recession, we saw a huge cutback on mental health services in the community. We're slowly restoring that. We have a lot more to do. But again, it's that data. That data will tell us where we need to make sure that we have services. I believe it's going to be on all islands, but then it gives us that information knowledge so that we can then go ask from the money committees, hey, we need to fund this.
Exactly. And then, but we talk all islands, and one of the issues that's come up has been, we can have this great IT system, we can have this record exchange information, but we need to have the broadband infrastructure, the bandwidth, if you will, to be able to do this type of exchange. Has this been something that, as a health committee, even though it's not in the purview of it, something that you are looking at and working with and for the other members of the legislature to ensure that this can move forward?
I think broadband and infrastructure has been a priority of this administration, the gubernatorial administration, and as well as the Senate and House leadership. I would actually defer to you, Chair, because that's really, I sit on the CPC committee with you, and we've seen all of these issues come before us. So yeah, broadband infrastructure is an important issue.
Well, that's why the 10 gigabit cable that's being proposed for Kaka'ako is something that's really big. You have the medical school there, the cancer school there, and their ability to be able to transmit large amounts of data, particularly that of specialist use for detection tools and imaging, is really something that will help to advance this in Hawaii. And so we have been cognizant working with you about the fact that you have to have the infrastructure travel with the technology. And it wouldn't be, without one, you can't have the other, so to speak.
Yeah, so, and that broadband infrastructure, it is public infrastructure. We need that to connect the islands and to connect providers with patients.
One of the issues that's kind of come up, with remote monitoring and other these things, remote scheduling, for instance, the idea of using remote consulting to be able to ensure that you don't have this lag time where the waiting room is empty per se and you have doctors on staff. But then the issue comes up because of this, will this be a driver for lower reimbursements, to continue lower reimbursements? Where do you see the collision between the reimbursements and the use of telemedicine insofar as not having a detrimental effect on telemedicine development and use?
Well, I think that's why that bill, Senate Bill 2469, is important, because it says that it has to be equivalent reimbursements. So we have to watch that. We have to ensure that we have providers on both sides who can deal with the patients, and then we have to kind of, I think, keep tabs on the insurance companies and to ensure that the reimbursements are equivalent.
Okay, we're going to go ahead and take a quick break, but we'll be back here to talk about more at health technology, telemedicine, and to look at disruptive technologies and how it could advance healthcare in Hawaii. We'll be right back.
Aloha, my name is Willow Chang Alion, and I host a show called The Art of Life. We air live every Friday from 2 to 3 p.m. And what we do is basically we focus on individuals who create a unique sense of place for Hawaii. These are movers and shakers, artists, innovators. They are also traditionalists. They're all involved in the archival process, and they make this place a unique.
I'm Hong Jiang, host for Asia in Review on Tuesdays.
And I'm David Day, host for Asian Review on Thursdays. Both of us broadcast our respective shows at 4 p.m.
And my topics tend to deal with questions related to environment, culture, history, and sometimes human rights.
And my shows tend to be on international business, foreign policy, geopolitics, and national security. And you can watch our shows live on the ThinkTech website at thinktechhawaii.com.
And you can also watch us on YouTube or Olalo.
So come join us on Thursdays at 4 p.m. I'm David Day.
And on Tuesdays at 4 p.m., I'm Hong Jiang.
Aloha.
Aloha.
Hi, my name is Dr. Rafi. Every week, I'm right here at ThinkTech Hawaii, 3 p.m. on Mondays. My show is Boards' Bio Briefings. What do we do here? Well, we watch sperm swim. We see if they catch anybody. We check out the latest biosimilars. You know, the kind that, what was his name, the guy with the bicycle? I guess we forgot his name, but he was taking EPO and other human growth factors. We'll be talking about human growth factors. You want to know where to get some? Maybe I'll tell. Anyway, you can catch me, as I said, every week right here, Monday, 3 p.m., ThinkTech Hawaii, Dr. Rafi. You can also find me on Twitter, BioInfo Medical. Or you can catch me on Facebook, Dr. Rafael Boritzer. I'll be happy to converse with you. Aloha.
Aloha, welcome back everybody to Facing the Future. I'm your host, Angus McKelvey, and today we're talking about telemedicine, technology as a way to tame or perhaps improve the ever-expanding healthcare universe. We were joined by Chair Representative Au Belatti in the first segment, and now we're joined by Chair Senator Roz Baker, Chair of the Consumer Protection and Commerce Committee in the Senate. And thank you so much for joining us today.
Oh, my pleasure.
On an issue that you have worked many years on. You were Chair of Health, and this was something that was near and dear to your heart. You could kind of see the wave coming, being a neighbor islander in particular, and through Ways and Means and now CPN, you're continuing this work. So to a person on the street who comes up to you and says, I hear telemedicine, telehealth, what does it mean to me? What would you say, or what is kind of the elevator speech to the masses?
Let me give you a real life example.
Okay.
It started out because we had two statutes. One called it telehealth for reimbursement purposes, the other called it telemedicine. Telemedicine was in the physician statute, so we needed to broaden it out so that other professionals who might not be MDs but might be primary care providers or specialty providers could also take an opportunity to diagnose and consult via telehealth. I had it come really home to me when I visited Lanai and their community health center. they don't have all of the ophthalmologic or dentistry specialists that they might need, but they have a wonderful telecommunication system. So they have two-way video, they have good cameras, but they needed the law changed so that their folks on Lanai wouldn't be disadvantaged by not having access to off-island professionals. And that was really one of the things that made us take a look at how can we make sure that folks in remote areas, whether they're on a neighbor island or the rural areas of Oahu, have an opportunity to have consultations with specialists who could really help them know, what's the correct course of action, what's the best course of action. And of course, in order to do that, you wanted to make sure that those services delivered by telehealth are paid equivalent and reimbursed equivalent to a face-to-face like we might be having here. So it started out on Lanai, and I just received a letter from them saying that the law that we changed is going to really help them out in terms of delivering more appropriate and better services and really helping people have access. So I think it's huge. And even before the law changed, although we did have to put this in the statute, there was a radiologic group that was coming to the tech park on Maui, and they were licensed in other states, but through some reciprocity, they were able to be here on vacation. Their families could come with, and they could enjoy the beauty that Maui has to offer, but they could read x-rays, they could read the films that were coming in from all over the place because the equipment was set up at the tech park. I don't think we have that service there any longer, but it was sort of the preliminary to using more and more consultations over telehealth. We've had telepsychiatry in Hawaii for a number of years, particularly between Oahu and Molokai, to help make sure that people were getting appropriately diagnosed and treated. But to me, telehealth and using the expanded telecommunications that we have really opens up great opportunities to make sure that even in remote Hawaii, we're not left out of the things that can help save lives and help treat diseases and treat conditions. But we don't have the same person in the room all the time. So that's why this bill
and
is
actually,
so important.
you now bring up a good innovative twist to this, to the challenge of, I discussed with Chair Belatti, that may appear on its face, of specialists not coming in physically anymore. But what your example here shows is that you could have physicians or groups who basically visit, part-time residents, others who could end up having patient relationships and teleconsult went back from where they're at as well as from Hawaii with their own patients, right? So there's a way to draw them in a little bit.
There is a way to draw them in, and it really, as we have fewer and fewer specialists, doctors, other kinds, we expanded a couple of years ago to advanced practice registered nurses, so they can use this as well. But I think what it does is it increases the opportunity for all of these kinds of specialties to be accessible in remote areas. And it may give opportunities, as long as we can get the bandwidth appropriate, to really help our brothers and sisters in the Pacific Islands, in Guam and Saipan and other places that may not have opportunities to have the full range of specialty observations, but it will make their health care better.
It really will, and the opportunity to be able to do this is incredible. When you were working on this bill, was there pressure or conflict between, because insurance companies nationally have talked about how telemedicine and teleconsulting will bring down rates and brings up the issue of lower reimbursements or holding reimbursements at a certain level because it's not a face-to-face consult, whereby, obviously providers need to be paid for this services. Was there a lot of pressure in developing this parity between face-to-face and telemedicine with some of the insurance companies who look to use this as a cost containment item?
I never saw that either when because I sit as the vice chair of the Health Committee in the Senate, either at that level or when it came to consumer protection. That wasn't the issue. I think in some ways we fought some of those battles early on when we were getting the Board of Medicine and some of the other providers comfortable with using telehealth. And so I didn't see that this time around. I think the interesting thing is, with the exception of behavioral health, there needs to be someone else in the room who helps translate, so that you don't have a remote physician or specialist talking only to the patient without having a primary care provider or somebody else in the room who can facilitate and really add to the richness of the discussion about the treatment or the diagnosis that the patient is undergoing.
Excellent. Disruptive technologies, you know, it's a key word, a buzzword that basically to take a technology that's already in existence for something else and to transform it to a new use. For instance, cell phones. They're no longer just for phone calls anymore. They're now becoming tools for people, and they're really emerging as tools in the world of telehealth. And, you know, do you see, I guess, that disruptive technologies, the use of these apps, mHealth and others, as being a way to not only create more opportunities for patients to access specialists, but to also become more engaged in their own healthcare decisions?
I think it's a double-edged sword. I think there's opportunities, just like with the internet, to learn more, but you don't want to get into the position of trying to diagnose yourself, because a lot of things mimic other diseases. But I think in terms of, like for me, I'm a Kaiser member, and so I get my test results, and I can get those on my iPad, I can get them on my phone, and then if I have questions, I've got it right at my fingertips to do an email back to my provider and get the information. So I think that's really how it's going to be useful. But I think in many places, Hawaii is sort of getting into this a little bit late, but many places, Florida comes to mind. All of the folks that deal with Quest providers have an iPad that has all the information. It helps you make sure that there's not bad interactions with drugs, because there's so many new things, new pharmacology applications coming out, and you want to make sure that, you know, you're not giving somebody one thing only to have it negate something else that another doctor is doing. And so some of those integrative apps, I think, can really be very helpful.
So in the hands of the professionals themselves, through this new disruptive technology, then you really could see the efficacy of,
absolutely.
You know, of being able to have this kind of access to. But you're right, I mean, you want to make sure that people understand you don't want self-diagnosis going on.
Yes, no practicing without a license. That would not be a good thing.
Well, speaking of that, we come to the, you know, an ever-present, the turf war issue. Perhaps, you know, sometimes you see it. Did that raise its head at all during this process, particularly with the different reimbursements between the different types of professionals? Has there been any, or have the groups come together recognizing it's an ecosystem approach that involves all of them as equal stakeholders?
You know, the one thing that I really see as a result of the Affordable Care Act and some other things that preceded it is really looking at the delivery of healthcare services as a collaborative. We talk about patient-centered medical home. We talk about the physician being sort of the team leader, but utilizing advanced practice registered nurses, utilizing licensed social workers, using a registered dietitian, using some of these other professionals to really advance the treatment that the medical doctor is providing. And so I think, you know, we're seeing more and more of a team approach, people understanding that they need the expertise and the technology that perhaps the younger members of the team are more able to handle. Yes. And I think that's a good thing. I mean, we're seeing it with our federally qualified healthcare centers. We're seeing it in small physician offices as well as some of the larger groups. And I really think that once the physicians become accustomed to the electronic health record, they're going to find that that's going to be a great tool. Now, I know the biggest complaint is, well, you've got to input everything. But there are physician's assistants, there are other folks who are very able to do that inputting, and then you have the advanced practice registered nurse or the physician actually look at all of that that's been inputted and then make recommendations.
And that's where another perhaps potential disruptive technology use could be, is for this voice recognition software like
Exactly.
Dragon and others to be able to speed up the input cycle so that people are freed up not to be tied to the computer the whole day.
Exactly.
You know, which is and that is a driver obviously to, you know, healthcare. One of the things that's come up in the universe of, you know, healthcare and technology has been the use of big data and trying to use some of these things in an anonymous way to create, you know, predictors or models or trends like that. Is your role of CPN chair, has big data, how has it played into both the information exchange and perhaps to trying to use it here in Hawaii as a way to address healthcare needs and perhaps drive down costs?
Well, I think data is very important because it drives some of the areas that we need to focus on. We look at population health, whether it's diabetes or cancers or some other areas. If we know that there are certain predictors that a population is going to have a greater incidence, say, of some kind of comorbidity or the risk of stroke or the risk of heart attack, then as a provider you can start looking for those, and you may order additional tests, or you may have a more extensive discussion about lifestyle and how those things might interact. So I think it's part and parcel of trying to make sure that treatments are tailored, that we know what the risk factors are and how we can help people avoid them or deal with them. So I think data is very, very important, and we're seeing it with the Hawaii Health Information Exchange because they're looking at those trends and pockets, and you know, is it a particular area that is having issues? We're also seeing that education, lifestyle, all these things, income levels, are really impacting health. And as long as we can sort of ferret some of that information out, we can be much more proactive. As a for instance, the folks in one of our community health centers here on Oahu discovered that their kids were just not getting any kind of dental care, even though if they were a Quest patient, they could get services. So they figured out, you know, how is that? Well, they didn't have a dentist. Well, was there some education that could be done either at the clinic? This was prior to the clinics being required to have dental services, or could they use the schools? And so you create a lot of different partnerships to try to make sure that good oral health, in this instance, information gets handed out. But you can also begin to engage the teachers. You can begin to engage the parents in a way that maybe they hadn't thought about it before. And so you really expand the reach of public health and public health services. And it goes back to being able to know the individuals, know what some of the risk factors are, some of the areas that you need to focus in on.
Well, that's compelling. The information exchange, you know, to me, what is putting us at the forefront of the big data move within health is the fact they're looking now to pools of data, which normally would not be associated with the traditional silo of healthcare, education, for instance. So, you know, as we move forward, the information exchange, do you see that perhaps working in conjunction with the Office of Information Technology, with other agencies, to pull some of these data from these sources that do play a factor in determinative health but are not traditionally included?
Absolutely. I mean, we talk about the social determinants of health, geography, social status, education. All of those things have an impact on the health of a population. And so using that, using the data, having the epidemiologists really look at that, and it helps us with policy. You know, what are some of the policies that we need to be looking at? Should we be going in this direction or that direction? How can we better engage our community health centers? How can we better engage, say, our community organizations or the ethnic or church-based organizations to get information out and get people to come in for a diagnosis or for some basic treatment?
and to help pull information in
Exactly.
there. Well, one of the challenges, as I discussed with Chair Belatti earlier, when you look at big data or information exchange, has been confidentiality and transparency vis-a-vis, you know, if you don't see all the numbers, then you can't really pull complete data. Has that been challenging for you in your work in this field, especially in the beginning years, the confidentiality issues, and what other types of things do you see as far as transparency or disclosure that could be or would be, should be looked at or needed to?
You know, as long as you aggregate the data so that you're looking at population and you're not looking at individuals, then you don't run into those privacy issues. And I think one of the things, as it becomes more specific and we're looking at specific genetic markers and genes, then you need to ask the individuals, you know, do you want to be part of this study? Are you willing to share the information about yourself because it has an impact and can help save somebody else's life? So I think we're starting to get into that a little bit more robustly than we did in the past, just because we have the capability. But there's still the federal law as well as the state law, and I think we want to make sure that we can aggregate the data, we can get it down to some subsets, but we don't necessarily need, I think, at this particular point in time, unless it's one-on-one doctor-patient, APRN patient, that you don't need to get it down to be that quite that specific to have validity and use.
Yes, and of course when you narrow it that specific, you run into dangers in and of itself.
Yes.
So as the information exchange moves forward, is there a plan or a, I guess, roadmap to start to pull this data into the policy-making arenas? For instance, especially when it comes to limited resources, do you foresee the exchange giving the data to the legislature, for instance, to be able to make some of these policy decisions and funding decisions within the next 3 years, 5 years? What type of, in your mind, do you see, I guess, the data coming into the policy arena from the collection stage to the, you know, this is the trends we're seeing stage?
You know, I think as more and more folks become a part of the Hawaii Information Exchange, then we'll have that capability. You know, currently all of the hospitals are required to do community benefit determinations, and so they need to be working out in their communities, and some of that information can be fed into the information exchange, and that would add to the richness. Right now, I think it's primarily hospital data, and so they need to get more and more of our doctors' offices being a part of that, so that, you know, you really have the kind of data that's going to help you look at trends, look at areas that might need a policy tweak, and I'm hoping that they will be providing that, but I think that's a number of years down the road.
But we're definitely, the map has been put together, which is really good.
Well, you know, you can see emergency room data, you can see some of the other infection data, and that's helpful. Because it gives us sort of the landscape of some of the things we need to be looking out for and be aware of. But I think we may be a few years off before we have enough data to really come in with some subsets of that.
And that's important, you know, for the public as well as, you know, for policymakers, is to make sure that the silver bullet effect, you know, that the data is here, it's going to conclusively do this, that we, you know, it's more of a, you know, what we need to let it come in, it needs to be analyzed, and you know, it's not something that's going to come in like a bolt of lightning. And to think that it will is kind of almost cutting your nose off to spite your face.
Yeah, exactly.
And so that's, in the area of data exchange and big data in technology, the issue of cybersecurity always comes up. I touched upon it briefly with our last guest. In your role as CPN chair, you deal with both universes, broadband and cybersecurity, as well as, you know, the information exchange and technology in health. How prevalent have been the concerns of IT security, cybersecurity, and what have you seen being done to try to address these issues as the evolution and creation of this new telemedicine health system emerges? Well,
it's always an issue because, you know, you think you have the best possible security system, and then there's somebody out there who wants to go after it. I think with the kind of data that we're talking about, it may not be quite as vulnerable to attack, because you're dealing with codes and diagnoses, and you're not dealing with things that are readily transmittable into cash. You're not
Yes.
dealing with, Social Security numbers. You're not dealing with credit card numbers and that sort of thing. So I know that it is encrypted, and they're trying to make sure that the best possible use of the data without opening it up to anybody using it in an unfit way or an inappropriate way. I haven't seen those issues come up like we have had with, dealing with getting information off of somebody's license, driver's license, or a credit card.
Well, while that that information doesn't present a low-hanging fruit for hackers, they do have the issue of the infrastructure itself. Does the infrastructure of the technology connection between the hospitals, the providers, does that create a gateway or opening for hackers to come in and bring the system down, so to speak? As you discuss or talk with hospitals and others who are exchanging this information, are they, I guess, moving forward in a way to look not only at the data itself, but also at the infrastructure and hardening it?
Yes, they are definitely concerned about those interfaces and those exchanges, because you're right. They don't want to be a gateway from getting the information for viruses or malware or other kinds of things to be infected. And so they're working very diligently with encryption and other mechanisms to make sure that their platforms are secure, because one of the things I think that took us a little longer in the health arena to get the ability to exchange information was the federal government had not come out with, you're going to do it this way, you're going to use this platform, you're going to look for these data sets. And so you had a lot of different systems crop up. Fortunately, with the expansion of technology, you can have different platforms, and there are ways that they can talk to each other, even if they're not all Epic systems or whatever the other major system is. But with that, they've had to make sure that their interfaces were secure and sort of convince the folks that are the lay people that it is there, and they've had it double and triple checked, because no, you don't want anything to come in that's going to distort the data or manipulate it in such a way that it doesn't give you the good results that you're looking for and the valid results that you're looking for.
And the things that they're looking at, one of the it's also some of the things you overlook. For instance, the disgruntled employee phenomenon. That one terminal that's unsecured, the password is left over, that they come back at a future time and could do that. So really working with the stakeholders in an ecosystem approach seems to really be a good fit for this as well too. Speaking of workforce, and one of the things is we face the future in Hawaii and new and exciting innovations occur. There's always this kind of initial reluctance, and have you found that, like, particularly one of the issues that's come up, in years past has been when this has come forward as, well, this will mean a reduction in nurses, this will mean a reduction and so some of these sectors start to express concerns that they're going to lose members or positions. Have you encountered that as when you first started going down this road, and how now, given what it is today, do you think that there's a new acceptance that this is not the case among the healthcare professionals?
I think the use of technology has really opened up additional positions for folks, and I haven't seen it as detrimental in terms of workforce. As a matter of fact, we're using technology to help better train our workforce. And you have people who can use the technology to really help them teach and to bring other people in. And with technology, you have new need for coders, you have new need for people to make the translation, looking at the data and making recommendations off of it. So we've really, I think, expanded the scope of a variety of professionals, and that just opens the door for other professionals to come in and be part of the team.
And it's a good, important opportunity to explain to those, because I've heard some of these reluctances, because it's new and it's like, it's just going to affect the doctor, but now with this technology, and you seem to touch upon it earlier, that this could be a tool for them to get greater efficiency and be more productive, and like you said, expand possible expansion of positions, like the voice data input, for instance,
Exactly.
right?
Well, you know, one of the areas that I've seen technology used with great benefit is in the training of doctors and nurses. We use simulators. We have Sim Baby and Sim Adult, and there's a Sim Pregnant Lady, and so you can help the trainees and the folks that are going through nurse and medical training to experience how they would react in certain situations without actually having a real patient there. And so it really broadens their horizons, gives them multiple opportunities, and of course that just creates new jobs in the process.
Yeah, new jobs and new positions. So it sounds like to me, as we face the future in healthcare information exchange and technology, that we in Hawaii are embracing it and looking beyond the traditional silos to get the most out of this. So, as we wrap it up here and bring it to the end of our show, do you think, in your role of CPN, that the evolution of technology in our healthcare universe is one that will allow us to bring down costs and greater allocate resources with greater effectiveness through the community?
I think it will bring greater efficiencies and better outcomes. Whether it will ultimately reduce costs, technology is expensive. I'm not certain on that. I'm a little kanalua on that. But I think it's something we need to embrace and utilize to its fullest, because I think the benefits will far outweigh the costs.
Yes, and that's why cost is not always measured in dollars and cents, but on these other intangibles that it seems that this will allow us to deliver. Thank you so much for joining us for this episode of Facing the Future. I'd like to thank my guests, Chair Belatti and Chair Roz Baker, for this discussion on our technology in our ever-expanding healthcare universe. We enjoy you to come and join us for future shows as we continue to face the future and turn over every envelope as we look towards new and innovative solutions for our issues in Hawaii. Aloha, and we'll see you next week.